Well, hello there and welcome. Welcome back to another Alliance Against Seclusion Restraint Live. Getting started here a minute or two late, but not to worry. We've got a great show on tap for you today. My name, of course, is Guy Stevens, the founder and executive director of the Alliance Against Seclusion Restraint. If you're not familiar with who the Alliance is and what we do, started the Alliance around 4.5 years ago. The Alliance is really about raising awareness about things like restraint and seclusion in schools. And not just about awareness, about changing things. So, and not just about restraint seclusion. It's restraint, seclusion, suspension, expulsion, corporal punishment, all the things that are often being done to people, very often in the name of behavior. Our work is really centered around how do we change laws and policies, but even more importantly, how do we change approaches? How do we move away from things that are perhaps well-intended but harmful? So we do a lot of work around not only crisis management and behavior management, but how we can change the way that we're supporting and working with people in schools throughout the country and beyond. Of course, we've got an international audience, always excited to see who's going to be joining us. And we have an international guest today as well, which is fantastic. Today, we are very excited to have joining us Sidney McGillicky. And Sidney is a certified EMDR therapist and approved consultant. And Sidney's going to be talking to us a little bit today about EMDR and how it can help in the treatment of complex trauma. I do want to let you know before we get into the show, a couple things. One, as always, today's session is going to be recorded. So it will be available to view, and you can view them live on Facebook, YouTube, and LinkedIn. You can also go back after the fact and view it on any of those platforms as well. We also make the shows available as an audio podcast. So if you want to go back later and listen in your car while you're doing things, you can download it on your favorite podcasting application, whether it be Apple Music or Spotify, whatever you might be using. Do want to ask you, I see a number of people have already jumped on, and that's fantastic. Excited to have people with us here on Thursday. And if you would, tell us in the chat who you are and where you're from. It's always great to see that we have people joining us from often all over the world. And I'd love to let our guests know who's going to be joining us. So let's go ahead and dive right into our main topic here today. And I'm very pleased to introduce Sidney to you. And as I mentioned, Sidney is an approved EMDR consultant and also a certified EMDR therapist who specializes in the treatment of complex and developmental trauma with 20 years of experience working as a therapist. Sidney is also certified in NMT, sorry, that's a lot, and level 1 practitioner, utilizing advanced knowledge and understanding of neurological development resulting from adverse and traumatic experiences throughout the lifespan. Sidney is a client-centered and really looking at the understanding and the consequences of trauma, developing interventions that focus on healing and recovery. And Sidney is also, and this is really important, I mean, this is gold star and a special hat, right? You are also a volunteer with the Alliance Against Seclusion Restraint. So I've had the opportunity to know you for some time now, and I remember some of our early conversations. It's always great meeting someone that is highly aligned with what we're doing, and certainly that's the case with you. And of course, you bring a tremendous wealth of experience to the organization as a volunteer, and we're really excited to have you here. So, Sidney, let me just begin by saying welcome and thanks so much for joining us today.
Well, thanks for having me. I mean, this is a privilege, and humbled and honored. And when you describe me as an international guest, I think that makes me sound more interesting than I am. But I'm going to go with that. So
you are very interesting, and I mean for us, you're an international guest, and hopefully we'll have people joining us from around the world to hear you today.
yeah.
I do want to remind folks as you're logging in, let us know who you are and where you're from. We already have a couple of people that have jumped in, so I'll just share with you. We've got Jennifer here, who's another Alliance volunteer from Davis, California. Trisha from Idahoans for Safe Schools. Excited to learn new treatments for my 3 complex trauma kiddos. We've got Sarah, another volunteer, joining us from Rochester, New York. Actually from Fort Collins, Colorado today, okay, in a different location. And Michelle from Kansas, Crisis Services Coordinator. So we've got a number of people that have already jumped in, and hopefully others will introduce themselves as they get on with us here today.
Yeah.
But we are really here to have a conversation today, and I am excited to learn more about you and the work that you do. And I think we titled this event about really kind of understanding what EMDR was and how it can help with complex trauma. So why don't we start at the top here? We know a little bit about who you are, and we'll learn more as we go. But let's start with something very simple. What is EMDR? Because I've
Yeah.
seen that around and I've heard EMDR, out there. I'm sure many others have as well. What is EMDR?
EMDR stands for, it's an acronym for eye movement desensitization and reprocessing. And it is a therapy that is client centered. And it really is a neurologically, foundationally based therapy. And I'll talk about that in a second. It was discovered by Francine Shapiro in 1987. She is a famous story where she was walking through Vasona Park in California. And she discovered through bilateral eye movements that the current issue that she was dealing with in her life suddenly seemed less potent, less bothersome. So from there, she developed what was called EMD and later became EMDR, as she discovered that processing was much more broad than just focusing on a single event. So EMDR uses the brain's healing system. It's a processing system that we call the adaptive information processing system. And it sounds very, very technical and I guess the word is technical, but it really is, it uses the brain's healing capacity to process information from life experience so that we're able to have able to live free from symptoms such as anxiety, depression, certainly traumas also is what EMDR is mainly known for. So EMDR has been developed in 1987. It has, I think, well over 100,000 clinicians in the world that's been trained in EMDR since its inception. EMDR is it's a client-centered approach, and it's a phased approach. So EMDR, we refer to it now as EMDR therapy as opposed to a specific technique. So EMDR therapy is a phased approach. It has 8 phases in total. And the clinician works with the client in collaboration, focusing on what the client is there for, and really adapting and tailoring, individualizing the treatment plan, the EMDR treatment plan, to address what the client is going through. So EMDR, the methodology is rooted in the AIP system, where the brain is able to process information in the neurons all throughout the brain, which is really, it is really, really neat. And part of my training is in the neurosequential model of therapeutics guy. So that's a brain mapping model that Dr. Bruce Perry's developed. So I took that training before EMDR. So I learned a lot about the brain. I learned a lot about developmental trauma, how adverse experiences throughout the lifespan and even single traumatic events in adulthood changes the neurobiology of the brain. And EMDR has the capacity to essentially reset, readjust, return the brain's natural functioning to a homeostatic state, so that I'm not in a hyper aroused mode or a hypo-aroused mode, you see. So it really is, it's very developmentally respectful as well. I'll explain that in a minute. And EMDR also has been applied to a variety of situations, conditions, mental health symptoms, because it's been around since 87. So what's the math on that? A little while. And every time
I've been around longer than 87, and you don't want to know my math. So,
Oh, I thought. So because it's been around for that long, it's been applied to a variety of situations, issues, certainly populations. And every time EMDR therapy is used to address an issue, then it becomes researched. So EMDR is heavily researched. It is actually one of the most researched therapies in the world. The World Health Organization, amongst others, now recognizes EMDR as a preferred, or you could say gold standard trauma therapy, and it's gaining recognition throughout the world. The Veterans Affairs in the United States recognizes it. The WHO, as I had mentioned, and it's just becoming more and more accepted as a very efficient, research-based therapy modality by itself to treat trauma, mental health symptoms, and a whole, like I said, addictions. Very effective in getting to the root source of addictions and in helping to improve the behavior. And so that is some of the methodology around EMDR, and the mechanics is EMDR has it's a phased protocol, as I've mentioned. So phase 1, we do history taking, getting to know our clients. Phase 2 is preparation, explaining EMDR, preparing people to do processing of painful or traumatic experiences. Phases 3 to 7 is the working phases, as we call it. And then phase 8 is a reevaluation of the work that we did. So that, of course, doesn't happen in one session. That happens over a series of sessions, you see. And so the EMDR clinician is really striving to achieve that collaboration, to understand the client's story, to begin to develop that treatment plan that's tailored and very, very specified to the client's current issues, current problems, symptoms, triggers, and so forth. So, I'll stop there because there's a lot to talk about with EMDR.
Sure. And I want to steer down a couple of paths here, but before I do, I'll just share with you, because again, I'd mentioned to you your international fame here. So on cue, we have people joining us from Australia. And also New Zealand. Anna,
my daughter's
said that EMDR.
My daughter's in New Zealand right now. Actually, yeah.
Well, we need to go visit. I'll go with you.
Okay. I'll carry the bags.
There you go. Great. And we've had a couple of people that have weighed in already as well. Sandra says EMDR is magical. I was able to release trauma from an event that took place 40 years ago. I'm interested in hearing how this model can be used with children. Okay, and we'll definitely can talk about that. Joe Brummer, a friend and author and amazing human being. He said, I had a therapist who did EMDR with me. He focused on cognitions. I wanted to change, but they seemed forced. Finding the right cognition was difficult, and I often felt I settled for one. I do think it helped. I'm curious if he was really doing EMDR. Thoughts?
Good question. Thanks, Joe. Yeah.
Okay. And of course we have somebody here from Canada as well. So let me back up for a second. And of course, the work that we do here at the Alliance, and of course the work around trying to eliminate the use of seclusion, reduce the use of restraint, move people in a better direction in terms of how they're working with and supporting children, often whose behaviors are leading to lots of really punitive consequences and really poor outcomes. But of course, in the in that situation we're talking about, where kids are being like physically restrained and secluded, I know through experience, not only my own experience, but the experience of many who I've had the opportunity to work with over the years, that a young child being physically restrained or secluded is traumatic. Is traumatic for that child, is often very traumatic for the family as well. Given your of that trauma, or dismissive that potentially something like restraint or seclusion could cause trauma, but given your background as a therapist, can you talk to us a little bit about trauma and what trauma does to an individual before we get into a
Mm.
little bit more depth around EMDR. So would you mind talking kind of at a high level of your your assessment around how something like being physically restrained or secluded could lead to trauma, and what that does within an individual?
Yeah. I know that. Yes. I mean, I was a school counselor for almost 4 years before I did all of this, moved into my private practice. So, Guy, I really lived in those trenches, and I, firsthand accounts of seeing students being, first secluded into a specialized classroom, and then restrained. And so it's that practice by itself is how do I say this? Well, I guess to me it's a little bit barbaric.
Mm-hmm.
And this has been talked about quite a bit, and I know that your audience as well oftentimes are sort of informed about what your organization does. And so for a child who needs to be or who are in those programs, oftentimes they're already having, of course, behavioral issues. My 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 expertise and my experience is mainly with those children who come from adverse experiences, who come from homes that there's neglect, violence, abuse of all kinds, children who are in foster care, certainly. So when you have those kinds of experiences early in life, it changes how the brain is developing. It changes the pathways in each of the area of the brain. And so we know this, neurosciences talks about this, the neurobiology of adverse experiences that comes from environmental experiences, certainly has a very, very, very strong influence in how my brain is sort of operating, how it's formed, and how it's functioning. So there's two things that happens in the neurobiology of the brain when I'm in these experiences. Even before I step in school, even before I even think about going to school, my brain will then become patterned to function in a hyper-aroused state or a hypo-aroused or dissociative state. Now, for children, those experiences, they're much more vulnerable because their brains are still developing, they're still being organized. Many people say, I won't drop their names here. Well, maybe I could, but many people say in the neurobiology, in the neuroscience, developmental neuroscience and neurosciences, traumatology, that mental health illnesses are not hereditary. Many people say, no, genetics does influence the creation and the vulnerability, but it is not the precipitating factor. It's the neurobiology that vastly dictates the symptoms of a mental health symptom that then becomes a disorder. And oftentimes, or most times, it's nothing more than neurobiology, but it is way more complex than just saying it's nothing more than that. So once we have a child who is exposed to even not having any contact, no physical touch, can cause my stress response to be in a hyper-aroused state.
Mm-hmm.
And then it'll flip away and it'll go down to a hypo-aroused state, dissociation.
Mm-hmm.
Now, if I have those experiences enough growing up from an early age to around 13, 14, 15, I'm very, very, my brain will pattern itself to function in that environment. It's patterned to function in response to the stimuli that it's being received.
Mm-hmm.
So,
and of course, when we're talking about
Mhm.
forced isolation, when we're talking about seclusion, I mean that
Yeah.
cycle that you're talking about. I mean, you can almost see that happen when a kid is forced into a seclusion room.
Mhm.
Kind of
Mhm.
hyper aroused, right? They're banging, they're screaming, they want to get
Mhm.
out. They're in a fight or
Mhm.
flight response mode, and after no no one helping them after 15 or 20 minutes, they
Yeah.
slouch against the wall, their head goes down, they become kind of hypo, and you're seeing that
Mhm.
shutdown, that brainstem kind of response, right?
Mhm.
I mean, this is really harmful, but people sometimes are doing it in the name of. I mean, people put kids in seclusion spaces
Mhm.
with the idea that somehow it's going to help a kid to self-regulate.
Yeah. Yeah.
Um,
Oh, I've not heard that before, like,
yeah,
ever.
yeah, yeah.
I'm I mean, pardon my candor, but it gets very frustrating when you see that happening to students, because a couple of key things: when we have children who have come from um, backgrounds of trauma, developmental trauma, hmm, um, then they're in these states of functioning. This is something I want your audience to really remember. A state of functioning means that I'm in a hyperaroused state of functioning. I don't have a choice to turn that off,
Mhm.
especially if I'm 5, 7, 9, 10, 15, hmm, and even into adulthood. And conversely, I don't have a choice if my brain is functioning in a dissociative hypoaroused state. Now, a state of functioning, you see, I'm emphasizing a
Yeah,
state of
yeah.
functioning doesn't go away, and I don't have a conscious choice in how I'm living in that state. Now,
And aren't these
what
really survival states? I mean, aren't these,
the,
our
these are
bodies doing what they're wired to do?
100% survival states.
Mm,
Absolutely.
mm.
These states operate beneath the cortices of the brain. These states operate in the stress response. And so the stress response is comprised of the limbic system, diencephalon cerebellum, and the brainstem. And so those are the main areas that we in the NMT model that Dr. Perry has taught us to assess, and that's where we kind of that's his model. Of course, there's a lot of other areas of stress response that's also impacted, Guy, but you're right. Um, they don't have a choice to be in that state of functioning.
Mm.
And then when they come to school, adults, what we see then is a tip of the iceberg phenomena, which is behaviors, non-compliance in the classroom. They can't sit still. Um,
Right, right.
Johnny's being bad. It's just bad. And they need to have some consequences. They need to begin to, learn and consequences. Well, these are cognitive behavioral mindsets. And I'm going to say this because Dr. Bessel van der Kolk has said this a while ago. In our society, North America, we have a cognitive behavioral bias.
Mm, mm, mhm,
And the cognitive behavioral bias, it comes from a lot of it from the medical model, and the medical model of treating and understanding emotional issues, mental health conditions is very kind of very um, I don't want to use the word rigid, but I can't think of a different
right,
word.
right, right.
Pardon me. The medical model treats the symptoms. The medical model, I think, also influences how we see behaviors, and if we apply a consequence to the behavior, then that child will learn to choose another behavior.
Mhm, mhm,
Okay,
mhm,
so
mhm,
let me unpack that for a second,
mhm.
because that's implying that my brain is not functioning in a hyper aroused, like you said, survival state. So I'm going to say this to your audience. Anybody here ever been pulled over by the police?
It happened
Sorry
to
to
my
say.
wife this morning. I was talking to my wife on the phone, and she said, "I'm getting pulled over." So,
So in that moment, when it
she's not
happens, if
watching,
you're having
hopefully,
a
or I'll be in trouble.
yeah. Um, so when that happens, we know what happens, right? Oh my gosh, maybe a few expletives. If you're me, your heart jumps up. You're kind of like one of two things: you're either angry at the police or you're angry at yourself. Now you get startled. Your brain literally goes into a momentary fight or flight mode. Okay. And so when that happens, my prefrontal cortex in that state of being in that survival state, it shuts down. It doesn't work efficiently, if at all. Now, now, imagine I'm a child. I'm 7 years old, and I'm living in that startled state. You might not be able to see it in my face. And so then my prefrontal cortex, I can't access it very, very well. Hmm. So how would a cognitive behavioral approach
Right.
work with that child's brain?
Right.
That's rhetorical. The answer is it doesn't work very well.
Right,
And
right.
so it
Yet so much of what
compounds.
we do is around that cognitive approach, and
Yes.
assuming all behavior
Mhm.
is intentional, right? Not
Oh, they're all
assuming.
intentional. Yeah.
Right,
Well,
right,
now I'm not saying that not all behavior is. There are some kids that intentionally
right.
do bad behaviors. Like I
And
get that
adults, right?
because yeah. Well, maybe your spouse for speeding. Just kidding. Um, um, yeah. And so now the main point here also I think is really has to be appreciated by the audience is that I can't speak for outside of North America's boundaries, but I do know here in Canada and I also understand in the States, schools who have these specialized programs utilize behavioralism.
Mm,
That is not effective to help a child, their nervous system feel safe, right?
mm,
That's an experience that a lot of these children don't have before they even step into a classroom
mm,
or a
mhm,
school
mhm,
or a school building.
mhm,
So
mhm.
how would a behavioral program as a starting point work? Again, that's rhetorical. They don't work very well. If they do work, they work out of compliance.
Mhm, mhm, mhm.
And also I will add, because we're talking about schools, and I'm going to say, here on the record that most group homes in North America also follow behaviorally based programs.
Mhm, mhm, mhm,
Trauma focused CBT can be effective if my brain can operate, if my brain can benefit from those approaches.
mhm, mhm,
But
mhm,
oftentimes they don't.
mhm, mhm.
So, do we have a dilemma here? Kinda.
Yeah.
Kinda.
So much of the approach, and I would agree with you. I mean, much of the approach being used in many schools and many other facilities around the world,
Mm-hmm.
are focused on compliance, are focused on the
Mm-hmm.
behavior, aren't focused on helping people to feel safe, aren't focused on
Mm-hmm.
understanding, where behavior really is coming from. And a lot of what we're doing, and you mentioned consequences earlier, and what was running through my head is it's not just the kind of the punitive negative consequences, but even the positive things, even things like rewards are not really helping our kids when we're using them in such a way that it's really about
Mm-hmm.
gaining compliance. It's not about
Yeah.
helping people to, yeah. So
Yep.
let me go a little sideways for a second. um, I mean, it sounds like you would acknowledge and agree that, for a young child, first of all, often the behavior that leads them to be physically restrained or secluded is often not a choice, but often as as you mentioned, kind of the state, right? It's often the body, when we don't feel safe, the body protecting itself, right? So a lot of this behavior that we see is unintentional, stress behavior, but the act of being physically restrained, I mean, and that can look
Mm-hmm.
like being pinned to the ground. That can look like, being held and carried against your will. It can look like a lot of different
Mm-hmm.
things.
Mm-hmm.
But you would agree that those actions that are taken can be traumatic to children.
Mm-hmm.
Um,
Mm-hmm.
so I guess the question is, one of the questions I get a lot as we work with families and others that have been impacted by this, whether self-advocate or whether a family have a young child that's been,
Mm-hmm.
physically restrained and secluded, the trauma becomes apparent, right?
Yeah. Mm-hmm.
I mean, I lived through it with my son, and I know there was a period of time that, um, we did not have my son. I mean, the trauma
Mm-hmm.
was so strong.
Mm-hmm.
So one of the questions is, well, what can we do? What can we help? What can we do to help a child heal from trauma? And of course, one of the important things is that we get them out of the situation where these things are happening. Because
Mm-hmm.
if it continues to happen, of course, we're just
Yes.
going piling on. But
Yes.
so talk to me about that as a therapist and an
Yeah.
EMDR therapist. What place might EMDR have in terms of an approach to trauma for
Yeah.
children, and what are the how might
Yeah.
that work, and what are the limitations on that as well?
Okay. I'll try to remember all those pointers. So
Sorry.
the first thing that I heard you say was there's different populations of children who are in these secluded and restraining school environments, right? So when we have a situation where I have either it's autism or Asperger's or some developmental disability entering, or a sensory processing disorder, those are organically based conditions. And if I come from a family that's nurturing, that's consistent, that's loving, that is healthy, that is a different child than a child that comes from abusive environments. Okay, so now with the child who comes to those programs, because we don't have a choice, right? We kind of need, we have to allow the school systems oftentimes to have our child become enrolled in these programs because there isn't a choice. So if I have a developmental disorder, such as I mentioned earlier, and I've never been restrained in my life, and my parents are loving, they're kind, they're consistent, and then I suddenly go into an environment, and by just a natural consequence of my condition can be behavioral problems, emotional problems, sensory issues. So then I can't sit still and listen. So then that child becomes a problem. And
Well,
then
the expectations are the problem, right? I mean, we shouldn't expect everybody to learn and do and
yes,
the same.
yes,
But
absolutely.
you're right. I mean, we have these expectations, and
Yeah.
think about a neurodivergent individual that might
Yeah.
best listen while moving around the room or walking. Yet we're
Yeah.
very rigid in the way that a lot
Yeah.
of these environments are
Rigid.
set up. Yeah.
So when a child in those experiences all of a sudden is restraint, that is tremendously, tremendously, tremendously fearful and traumatic, because trauma is subjective. So what I mean by that is that my experience of trauma can be different than yours. An example being is if my parents were married for 15 years and suddenly they got divorced, and that just crushes me. But let's say that your parents have been married 5 times. So that experience of the breakup won't be nearly as traumatic. So the experience of trauma can be subjective, but my nervous system doesn't interpret it that way. So if I'm being suddenly restrained and held down and secluded, that is tremendously fearful to a child who's never experienced that kind of violence, because that's violence towards children. Bottom line, that's what that is. And so
I agree with you. Restraint, seclusion, corporal punishment. I mean, it's violence against children.
Yeah, it's violence against children. And I know the arguments. I've heard them. I've debated them from time to time with those who don't believe that perspective. But this perspective is coming from neurobiology. This is less of my opinion and my beliefs than it is coming from neurobiology. So the neurobiology being held down and restrained, oh my God. So I had an uncle, my Uncle Mark, he's deceased, and he was a fun-loving uncle, right? Lovely guy. But I was claustrophobic as a kid, still kind of am. So you know what he did that was fun for him? He held me down one day. I was maybe 8 or 9 or 10, and I freaked out. But I knew I was safe. I knew he wasn't, he was going to let me go. So now I've never forgotten that. You see? So to answer your question, like the bottom line, Guy, is in those situations to a child who's not used to that kind of violence is especially traumatic. And it creates that, like the fight or flight system that's deep in the brain in the stress response. It activates that. And it can aggravate existing symptoms. Right? It also can disrupt my functioning, sleep patterns, symptoms of anxiety can develop or worsen. All kinds of things happen. Now, to me, laying hands on a child who has autism, and I know what the argument is. They'll say, well, we didn't have a choice. That student was putting us in physical harm. We had to do this because we had to keep ourselves safe. right? That's the argument. And to me, that is an excuse, not an argument.
Well,
That's an excuse.
and an indication that you don't know what else to do. And I think, very often when we find
Mm-hmm.
people that are doing these things extensively, because the more they do it, the more they end up doing it. It seems, and I think part of that is related to
Yeah.
their own trauma. It
Mm-hmm.
is in fact traumatizing to hold a kid down and restrain them. I mean, that's not something that is
Yeah.
easy for you to think about as a parent of a kid that had this happen, but it is
Yeah.
traumatic when the arms are flailing and they're kicking.
Yeah.
And unfortunately, the more someone does that to someone else, the more they're likely to be traumatized, the more they're likely to be hypervigilant. The more hypervigilant they are, the more likely they are to go to an intervention like a
Yep.
restraint that they know, even if it's not working for them, because of the trauma. When we become
Mm-hmm.
stressed to a level that we can't cognitively rely on our cortex, we go down pathways that are well walked down. Right? We
Yeah.
do the things that we know, even if logically they're not helping us. Right?
Yeah. Absolutely.
Yeah.
And also, the trauma then becomes the trauma spreads to, like you said, the staff members, in a different way. But then as parents, like, wow, that's very traumatic for a parent to know that my child is being restrained.
Oh,
My child is being
absolutely,
restrained
absolutely.
for a developmental condition, and they can't help themselves.
Right. My child's being harmed, and there's nothing I can do to help. Right. I mean, it's a
So
feeling of helplessness.
yeah,
You
so
know.
then what happens then is parents experience um, um, secondary traumatic stress. Parents now, secondary traumatic stress is a phenomena that I did my thesis on, actually, but it is something that is a phenomena when I if I'm exposed, if I hear about a traumatic experience, if I view a traumatic experience, or if I know about a traumatic experience, I can have a traumatic response within myself. Secondary traumatic stress.
Mhm.
Parents, family members, teachers, other students are all suffering from these situations. You see?
Mhm,
Mm.
mhm, mhm. So talk to me then about knowing the stressful impact.
Mm.
Um, how might EMDR be helpful for, let's say, both a child and a parent?
Yeah,
Talk to me about that.
yeah. So with children, EMDR has been applied for since its inception. Applying EMDR to children is not oftentimes not as straightforward as with adults. Um, Therapists who apply EMDR to children should really have some level of play therapy training
Mhm.
and EMDR before they begin to apply it. That's been recommended. It's been recommended by numerous people. So EMDR is highly effective for children, Guy. And when we use EMDR for children with specific situations, as you're talking, you can clear the trauma in the nervous systems relatively faster than adults.
Mm,
You see?
mm, mm.
Now, there still is a preparation we have to go through. We have to understand the family dynamics. How much support is there for this child? That's going to dictate uh, how we apply EMDR to that child. It does essentially EMDR with children uses the same protocol steps. The mechanics are the same. The methodology is the same. We just have to adapt it for different ages, different stages. Um, um, uh, Oftentimes, we have to know the difference between non-directive and directive play therapy. So there's some little nuances and technical things to consider, Guy. But I have worked with kids with EMDR, and oftentimes I'll use Santray as part of my training. I also have my full play therapy training and different certifications in sound play, trauma-based play, and my EMDR, and a bunch of EMDR training. Um, I'm going to shout out to Anna Gomez, who is one of the leading EMDR child experts. And so when we are able to apply EMDR with children on a specific situation, and sometimes there can be clusters of experiences, the processing, when we're able to get into those memory networks, the processing happens fairly rapidly. Yeah. So what we're doing is we're relieving the nervous system of the burden of being in fight or flight with children and adults. Both children, we're intervening as the neural circuits are being formed. You see? So with children, when we can intervene before their circuits are finished maturing, then we can intervene much faster. Then they won't be carrying these symptoms into adulthood. You can still treat these symptoms in adulthood. The brain has neuroplasticity all throughout, so these aren't permanent wiring. However, when I'm an adult, the more experiences I have, more layers, then there's more neural information to process from an experience or experiences. So children, they're still forming those pathways. So that's why the processing happens a lot faster. You see?
So let me ask you a question. Thinking about, and we talked a little bit about kind of the population of children that are more likely to be, restrained and secluded. And of course, we know that children with disabilities, children with an IEP or 504 here in the United States, would be more apt to be, restrained and secluded. We break that down. Autistic children are highly disrepresented, in that data. And, another kind of, aside from, again, we often see kids with communication differences. So maybe non-speaking autistic children. I'm kind of curious, based on your experience and based on your knowledge, are there people that are working successfully with non-speaking individuals with things like EMDR? Or tell me about that. I'd love to hear about that.
Yes. So yes, there are, as I said earlier at the start of this interview, EMDR has been applied to a wide variety of populations and issues. EMDR is applied to, there are protocols and training and experts in the EMDR community who apply EMDR protocol to children who are nonverbal or have limited verbal skills, children who have autism or on the spectrum, and others. And so it is applied. Now you have to adapt it. EMDR, I didn't say this earlier, Guy, but EMDR is very fluid. It does have a specific protocol and steps to follow, but it is very dynamic. And it is it's very fluid in the sense it can be flexible to be adapted to a population, to nonverbal, to I have done EMDR on a 16-month-old once, but there's a way you do that, you see. So you can. It does require that therapist to have a couple of key things. A lot of experience in EMDR with children. Certainly they need to know the population. They need to have some specialized training, and also consultation or supervision. You see, but there are people I know. People are applying EMDR to these kiddos, to these population, and so it can be done. It is a bit of a niche. It's kind of a specialized approach, I would say, but it can be done, and it is done. And so, and the thing about that is, if I'm in that situation, and if someone's listening who is in a situation, it's very important to reach out and find that qualified EMDR clinician. So there's a bit of quality control, but also to don't wait. Don't wait. The longer we wait, the more that nervous system would be patterned to function in that mode, you see. So intervening as early as we can is necessary. And if you can't intervene early, that's okay. No, that's fine. Still the positive benefits will happen when we process. So nonverbal, children who are on the spectrum, autism, Asperger's. Yeah. So I think I answered the question.
Yeah, absolutely. Well, and I want to pivot for a second, and we have a lot of conversation happening in the chat. So I want to take a moment and kind of pivot over there and get some questions and comments. When we were talking about kind of, I think the cortex going offline and the idea that, what happens when somebody is having a stress response. Jennifer said, the favorite question when a child does something, the adult says, "Why did you do that?" And the kid looks and blank shrugs their shoulder. Often makes
I
the
don't
adult
know.
feel even more angry. But I mean, how many times have you asked, "Why'd you do that?" I don't know. My son, when he was very young, he would say, and I love this because it was actually really, really meaningful if you took it apart. But he said, "My brain made me do it." You know. Um, Devona asked, "What are examples of intentional bad behavior?" So we were talking
Mm,
about, and I'm a huge fan of people like Dr. Mona Delahooke, and of course she talks about kind of body up or bottom up behavior, and then kind of
yep.
top down or cognitive behavior.
Yeah.
And certainly, I think you would probably agree that with younger children with less developed brains, when you add trauma or you add neurodivergence, more and more of the behaviors are probably coming that bottom up route. But you kind of called out that there are kind of intentional behaviors. So what
Yeah.
would your example be of an
Yeah.
intentional?
So when I say intentional behaviors, it's a little bit deceiving, right? So I'll try and unpack that. There's a couple ways I can answer that. So, mm, and now, an intentional bad behavior means that I have the presence of mind, um, that the intentional bad behavior, um, yeah, sometimes kids just act like little orangutans because that's what kids do, um, right? Or maybe fun, or these kinds of things. But when we have the perspective that you're being bad, then the adult is interpreting that this child is suddenly trying to control me, control the situation, control the environment. Hmm. So there's that kind of aspect. But when I'm going to use the population of the children who are come from those experiences, environments where there's developmental trauma, and they come from neglectful environments. These behaviors are often referred to as survival or protective mechanisms.
Mhm.
Hmm. So there are also traumagenic states that uh, Liliana Gill in her book talks about. I'm just looking at her book
Oh,
right
you
now.
look at the bookshelf there, yeah.
Right there. Traumagenic states also has different categories. These are for, again, these are the population of children who come from those environments that I referenced earlier. Um, and um, so they begin to behave. They can become manipulative. Mm-hmm. They can assert control in the environment. Correct. Mm-hmm. They can, try and control the crowd. They do all kinds of things that are survival behaviors because those behaviors are less learned than they are out of necessity. Hope that
Mm,
makes sense.
yeah.
These
Well,
behaviors are out of necessity, not learned behaviors.
mhm, mhm.
Now, there are behaviors that are learned. I'm not saying that all bad behavior is unintentional, but I would say that percentage is like unintentional is here and unintentional is here.
Right, right.
Yeah.
Right. Well, and Stuart Shanker, the Merit Center,
Yes.
brilliant.
Yeah.
I'm such a big fan of Stuart Shanker's, but he has a saying, there are no bad kids, right?
Yeah.
Um,
Yeah. Yeah. Yeah.
I love that. But even in terms of okay, so a bottom up behavior being kind of a stress behavior, a body
Yep.
wired to protect
Yep.
itself, protective behaviors. Top down being thoughtful and cognitive.
Yeah.
My leaning is to say that. Assume a stress behavior. If you assume a stress behavior and you're wrong, there's no harm. But when you assume intent and you're wrong, there can be harm. So, I mean, I think you're always better off to assume that this behavior was not necessarily intentional. And what does a kid need? A kid probably needs connection. Kid probably needs support. So let's start out with let's assume the best of kids and of others. And again, I
I
think
love
when
that.
we,
Let's just
yeah, yeah.
assume the best.
Yep. All right, let's get to a couple of other things here. Jennifer said, my son has early pre-verbal trauma. Developmental
Oh,
pediatrician wanted to do CBT
yes.
when he was 6 or 7. My first thought was he doesn't even have cognitive memory of his experiences, which were medical, so medical trauma. And apparently the doctor fired them, which probably was a blessing. And any thoughts on that CBT on a 6 or 7-year-old?
Oh, Let me just gather myself here. I'd probably say, yeah, no.
Yeah, yeah. So,
Because if I say yes, then I literally have contradicted everything I've said in this last half an hour.
right.
If I say yes to that question guy, and if I agreed with that physician, then I'm discounting how many years of neuroscience research.
Mm-hmm, mm-hmm.
So we say intentional bad behavior. So do I need to be intentionally, willfully ignorant to agree to a behavioral bias? Now that's loaded. That's a loaded statement. I get it. However, preverbal trauma is highly treatable in EMDR.
Mm-hmm. Okay, great.
I often treat preverbal trauma with adults. There's protocols and there's approaches that I have training in and that EMDR therapists can be trained in. There's a way in which we can access that preverbal memory, preverbal experiences, because one key thing I want people to remember, we talk about memory, but memory is experiences the brain is cataloging. The experience is all throughout the brain, brainstem, midbrain, limbic, cortices, and memory is not localized in any one spot in the brain. Memory is everywhere. And so preverbal trauma, we can treat that. You would not treat preverbal trauma with CBT because Jennifer's comment was spot on. CBT with children is now if a child has a brain that's well organized, not neurodivergent, is healthy and functional, you can do CBT based things. But when that's not the case, CBT, you might as well go spit in the wind. Because the prefrontal cortex, yes, it's not developed well enough to benefit from CBT. And if there's any neurodivergency in my nervous system or any aspect of developmental trauma, as I was saying earlier, how is that going to even work? The question, that's rhetorical. It's not. See? So, but as I was saying before, Guy, this leads to another point, which is, remember the cognitive behavioral bias?
Right.
That's so entrenched in our system.
Right.
It's so entrenched. Now, hang on a second. It's so entrenched in the publicly funded mental health systems in North America, school systems, group homes, and I can go on and on and on. Physicians, doctors, even therapists. So then we say, needs to go talk to somebody. We need to go do CBT. Now, CBT works really well. CBT is remarkably efficient when my brain is able to access the prefrontal cortex without it being hijacked by my lower parts of the brain.
Which is why EMDR would be such a good fit for trauma, where your brain is far more likely. Yeah. I'm following you here. All right, let me get to a couple more thoughts here. Sandra said, can you talk about trauma and its potential relationship to generalized anxiety? Is EMDR effective for generalized anxiety that may or may not be associated with trauma?
Yes. So, Sandra, the answer is yes. Generalized anxiety is a symptom of neurobiology. So, here's how I'm going to answer that. Now, remember, my brain is patterned to function through experiences. It doesn't have to be exposed to traumatic environments. It can be exposed to parents who are stressed out constantly. It can be exposed to moving around all the time. Any experience that the child's nervous system notices that's stressful patterns that to be in a heightened state. So hyperarousal in the brain creates symptoms of anxiety. And what do symptoms do? They become a diagnosis. They become a disorder. Generalized anxiety means your brain is in a constant scanning mode for threat. So it's tricky. So yes, Sandra, you can treat generalized anxiety effectively with EMDR, very effectively, actually. And I do have a number of patients I have treated and children with generalized anxiety. And so, yeah, anxiety is highly treatable with EMDR, highly treatable. Yeah. Yes.
You just said something that launched another thought in my head here. Are you familiar with Stephen Porges' work around the polyvagal theory?
I've been referencing it actually.
Okay. Um,
Yeah.
so,
Yeah.
so, so, so what I was
Yeah.
thinking here is in
Yeah.
terms of like
Yeah.
faulty neuroception and generalized anxiety, it
Yeah.
would
Yeah.
seem like
Yeah. Yeah.
that's really kind of okay.
Yeah.
So we're on the same page. I was like,
Yes,
well,
sir.
that sounds very, very much aligned. All right, let me get to
Yeah.
something here from Renee. This is a long one, so give me a second here. EMDR has been a lifesaver for my son. He did
Ah.
play therapy for many years, but
Ah.
really turned the corner with EMDR. He developed post-traumatic stress disorder after being secluded in a closet at a school for a whole year without my knowledge. Renee, I'm
Mm.
sorry to hear that.
Mm.
His first suicide attempt was at age 9. It's heartbreaking.
Mm.
At that time, I didn't know what was going on at school. He has high functioning autism. It will forever haunt me why he didn't tell me what was happening. A
Mm.
mother of another student called me to tell me about it as my son was screaming, and it looks like it got cut off there. So we didn't get the whole thing. Yeah, and what a yeah. I don't. Let me just see if Renee came back on here with more. So it sounds like a really traumatic experience, and of course, Renee, I'll mention to you. You said you don't know why you didn't know, and so often, when this is happening to kids, a couple things happen. One, kids sometimes actually assume that their parents or caregivers are somehow magically aware of everything that happens to them, especially young kids. They assume that we know everything that happens to them. We sent them to this place, and we must know what's going on.
Yeah. Right.
But then of course you have kids that are steeped in shame. They have been learning to see themselves as a bad kid, and they're getting these consequences because they're a bad kid.
It's my
And
fault.
yeah. They don't want to come home and say, guess what? So I think there's a lot of reasons sometimes that we don't know that these things are happening, and of course we should. But it sounds like, this is a case where, somebody's really gotten the heart of what part of what I want to talk to you about, which is, what's the applicability of EMDR for survivors of restrained seclusion in school. And it sounds like from Renee's experience and what you've been sharing with us, that this might be a really good path for people to
Yeah.
consider if they have a
Yeah.
child. And it sounds like what you're also saying is, do it sooner, not to
Sooner,
wait. Yeah. All right. Let me see what else we have here.
Well, I sorry, Renee, I'm sorry to hear about what happened. That it's horrible. And there's lots to say about her case, but
Yeah. We've got to do better. We've got to do better. The fact that these things are still happening in schools, when we know so much better. Yeah.
And one of the key points, guys, I'm just going to jump in quickly. I'm sorry, folks, to get when we're in those situations, like so in schools, right? Children who are in these programs or who are become restrained and secluded, there's inherent power imbalance. I'm in fact now way more helpless than I was before, and I'm at fault. Think of that rhetoric. I'm having an emotional crisis because of a fight or flight response or whatever the situation is. And then I have a teacher, well-intentioned or maybe not, who's peering at me and grilling me of questions or telling me about the consequences. That's even before I've been restrained. Now, if that happens, of course, children, we get confused. If I tell my parents what happened, what might happen to me? So children can lock this up and they can internalize the experience, and that's dangerous because if I internalize that too much, it becomes emotionally, in a way, cancerous. Then what happens is, then I can have that rumination, develop symptoms of depression, low mood, and again, that's neurobiology. But when I internalize it and I don't tell anyone, suicide is the result of helplessness. You see, oftentimes.
Mm-hmm.
And it is depression can be an invisible trauma until I see something like a suicide attempt or ideations. Yeah. Yeah, does that make sense? Because
Yeah.
that does happen. That
Yeah.
does happen,
Absolutely.
and
Absolutely.
we shouldn't kid ourselves that it doesn't happen. Now, you can see how passionate I am. I probably maybe I'm a little scoldy here, and I apologize. But I don't apologize for adults who don't do better when they have a choice.
Mm-hmm, mm-hmm, mm-hmm.
And I'll pause it right there because um, I get so enthusiastic, and my the protective dad comes out when I hear these situations.
Mm-hmm,
So I
mm-hmm.
have to
Yeah.
maintain some decorum here. But yeah, you're welcome, Renee. Yeah, you're welcome.
So let me get a couple of other questions here. Angie said, well, we were talking about what was happening as child abuse. Let's see, it's also trauma for a parent when finding out this happened to your child. And we were talking about that earlier. Absolutely traumatic. And of course, our stress response system then is on high alert, which can make things very difficult. But the question here is, can EMDR or art, can EMDR or art help reverse the damage done? I think I know the answer here, but I'll let you take it away. I think I'm learning.
I can't say about art therapy because I just can't comment about that. But I can say with EMDR, oh, absolutely. Now, a couple of things that I'm going to talk about with EMDR is it doesn't change. It can't erase memory. It doesn't change the aspect of the experience. What we're trying to do is reduce that trauma response when I think about the experience or the existing response of the trauma from the experience. Does that make sense? Yeah. Yeah. You see? Everything else applies when it comes to parents, and again, I would also stress that if I have a child like such as Renee's situation, and if I was Renee's, if I was their therapist, I would say first I would have to assess how the parents are responding, and if the parents have some level of secondary traumatic stress, which would be impossible not to, I would say, okay, let's treat you folks first if we can, or in tandem, so that then your child will have a caregiver who will be able to be there and provide the full amount of emotional support, right? Not that you can't if you're having secondary traumatic stress as a parent, but it's very important to also treat the family, not just the child.
Yeah, I mean, it comes down to the kind of the you first principle that I think is so important. That and I think this is really true of our educators. And educators that may have trauma in the classroom, like your own trauma can really be manifest in the classroom, and it's important that you're getting the help and support that you need, because if we are dysregulated, we're not going to be helpful to a child who's having a hard time, right?
Right, and that's something that's so important. That's so important. We often, I'm not trying to vilify educators because they're people too, and there are a percentage who need to be vilified. It's probably a small percentage.
Yeah, I mean, it's the outlier. I mean, I honestly, I think most people go into education because they want to help, right? They want to do good.
Yeah.
But
So
the system sometimes prime people through compliance to doing.
So if I'm an educator, and if I have any history of trauma or anything, or let's just say I'm just life is dealing me a bad card, they also need to be regulated, and they also need to be there needs to be compassion for them as well. And so educators are human beings. I get it. This population is very hard to work with, especially in schools. I know that firsthand. Yep. So, most educators are well-intentioned, and I've seen that. Most of them are. But once you get into a system that is operating from seclusion and restraint, behavioral bias, then you either have to get with the program, or what's the option? Conform, or
well, and I will say, Sidney, we actually have a number of educators we work with that have been educators that have stood up against systems, and
Mm.
some of them
Yeah.
have had really significant impacts of changing systems, but it's
Yeah.
usually been at some personal cost. It's not easy to take on a
Yeah.
system, whether you're a parent or an educator.
No, 100%. Yep. So, yep. So, I mean, teachers are so one of the things, I mean, when you have a teacher who's dialed into the classroom, who's attuned to the classroom, that child will feel so safe. That child will feel so regulated that their prefrontal cortex now is available to learn. And that child will not forget that teacher. I had a grade 3 teacher. I can't remember her name. I can see her face. And she was firm, and I was hyper aroused, right? I probably caught the ADHD, I'm sure. But she worked with me. She was firm, fair. And I got to tell you, Guy, I can see her face right now. And I was in grade 3 or 4. You see, I've never forgotten her. So she was influential. And I think one of the messages I would say is that teachers, educators, you have so much influence on the development of the child. It's not just about teaching them.
Right.
And
Right.
I know
Right.
I'm preaching to
Not
the
not
choir.
not at all just about teaching, right?
Yeah.
Especially when we're talking about very young kids. When we're talking about kids that are
Yeah.
5 and 6 years old, I don't want to hear that your job is just to teach academics. You're helping to raise a human being when you're a teacher of a
Human
very young
being.
child with an undeveloped brain, right? I mean, that's part of what we have to do and have to look at it.
Yeah.
We're nearing our time here, but we still have a number of
Yeah.
questions. So I want to
Okay.
try to hit a couple of them before I let you go.
Yes,
Sandra
sir.
had a great one here that said, "When do you know when a child is ready or a good candidate for EMDR?" When I did EMDR, it was draining and I was exhausted after each session. It was difficult work. I held off going this route with my child because I don't know how hard the work will be for her. So, any thoughts on that when a
Yeah.
child is a good candidate?
Yeah. So there's a bunch of factors that the experienced and trained EMDR child therapist would consider. Factors such as the environment. So if a child's in foster care and this is their 5th home in 6 months, probably can't get to the core memory, but you can begin to work with them to develop skills of co-regulation, getting a good therapeutic rapport, and those are pieces in the preparation phase of EMDR. If you have a situation where the child has a good, loving family, and the family can provide that emotional support to help the child through any post-treatment symptoms, because it can be draining. EMDR is something that we consider post aftercare considerations, such as the home environment, the attachment quality, their capacity, the history. A lot of things goes into the decision, Guy, for us as EMDR child therapists to move into the processing or the working phases of the experience. There's different ways in which you can do that. You can process with children in the sand tray. That's accessing the experience from a distance. So you can titrate it. You can do all kinds of things based on the need of the client, because the EMDR is client-centered. So it's not that you wouldn't not start the process. You can start the process, but really talk to that therapist about these concerns so that they can pace the EMDR therapy. You see? Does that make sense?
Yep,
Yeah.
absolutely. So I have another comment here from Linda. It says, hearing how important it is to get started rather than to wait is really valuable. And heard that from you, Sydney, the sooner the better, right? And apparently just getting started investigating EMDR as a tool last week. Thank you for sharing. I'm going to turn that into a question. And the question is, what guidance would you offer to, say, parents that might be looking for a EMDR therapist for their child that has experienced trauma? So are there places to go look for therapists or things that they should look for in terms of finding somebody who would be appropriate to work with their child?
Yes. Yeah. So if you go to EMDRIA, and if you're in this, EMDRIA is the international organization that governs EMDR internationally. So there's EMDR Canada, EMDR Australia, UK EMDR, I think it's called. So if you go to EMDR's website, and there's a tab on there that says Find a Therapist. So you put in your geographical information, and it'll generate a list of those who are part of EMDRIA. Not every therapist registers themselves with EMDRIA or are members. So that's one way to find an EMDR therapist.
Can you spell that for me? What's the link there?
Yeah, EMDRIA, EMDRIA.
Okay, gotcha.
Yeah, and also you could also go on to like Psychology Today, put in your location, do an EMDR search, and you'll get those who are trained in EMDR. Okay, so that's the first step. The second step then is to, my preference is to find somebody who's either certified in EMDR or a consultant. There's more certified EMDRs therapists than there are consultants. So if they're certified, that means that EMDRIA has qualified them as to having mastered the basic protocol. The third thing I would also look for is what's your experience in training in working with kids in EMDR? And so if they say, well, a lot of experience, but I did a workshop for a weekend 10 years ago. It's not, to me, that might not be the best option. So does that answer the question?
Yeah, I think so. And let me add two little follow-up pieces to this.
Yeah.
One person, Carol asked, can EMDR be done through telehealth, or does it need to be done in person?
It can. It's better. It's best with adults and children, I would say. You can do telehealth. No, you can do EMDR with children through telehealth. I don't practice that way, so I don't have that expertise. I do know, though, Carol, there are people who do specialize in that, and there are ways in which you can do it. So it can be done, Carol, for sure. So it can be done through telehealth, virtual, with adults and kids.
Okay. And Linda asked, we're going to make this our final question here, and then I'm going to ask you if you have any final thoughts. But Linda asked, like, how do you get a child on board with this, especially a child that might feel like, we've done all that therapy, they know the tools. How do you help bring somebody along to be receptive to this? Any
first thing I do with the kiddo is I get a rapport. They have to feel, we have to get a relationship. Like that's priority with kids. Yeah.
But before they even get to you, though, I mean, like, what might have? Yeah, I mean, because I know you're going to do that, and I know you're going to be great at doing that. But let's say there's a kid that's gone through all of this, and mom says, "Hey, we have this new thing." Any recommendations on getting somebody on board before they have a chance to even meet you?
There's videos. There's some videos that have been produced. I can't tell you where they are, but I know that there are videos that children can watch that are designed to do what you're asking, Guy. It talks about EMDR in child-friendly language. There are certainly some. I think videos is probably one of the important things. There's also, there are some materials you can read to children about EMDR. Anna Gomez has some books about EMDR. There's also some videos that are geared towards children that talks about EMDR that people can present to their child to begin that to begin the buy-in process. Yeah.
Mm-hmm. Well, and that's just it, right? I mean, it's treating children like you would want to be treated yourself, and giving them the information, explaining it to them, and getting them bought in. I mean, too often kids are on the wrong side of having things done to them or for them. And, sometimes it's really important to actually to get the buy-in, to say, hey, this is what it is, and this is what we're thinking about. And here's a video. And if you think of some of those after the fact, share them with me, and I can always share them online. This has been a really great conversation, and our time is coming to an end here. But I want to give you an opportunity, if there's anything else, any final words you want to leave us with in terms of, our conversation here today. So this is your opportunity for that last big strike of wisdom here.
Ooh, the strike of wisdom. Do what Guy says. I'm just kidding. I would say, thank you for the opportunity. I think it's important that we begin to advocate for change with our children, And if it can't happen with the teachers, we can access school board trustees. We need to begin to respectfully question the efficacy of what's being done to our children, because they're vulnerable people. And I will not apologize for hurting a teacher's feelings, because I think, to me, the child's best interest usurps adults' best interest. So what I would say with that is I would say thank you for the opportunity to share what I have learned. I've learned this. You see, I haven't come up with all this stuff. I have learned this from other people, and I keep learning. So keep learning about your child. Investigate EMDR, and I think we need to band together as a community and begin to advocate for change, because we're talking about development of a human being. Yeah, that's important.
Absolutely.
Yeah. So
and there's so much that relies on that down the road, right? I mean, so many things that we're doing now.
Yeah. So I'd say thank you. I've got gratitude for having the opportunity, and I hope this made sense, and I hope this was beneficial.
Yeah, no, absolutely. It's been a great conversation. I a couple light bulbs going off in my head here, and I always enjoy doing these because it's a great opportunity to, as you said, continue to learn and learn from the experience of others. I think one of the take homes here that is really important to me is, one, understand and acknowledge the potential trauma, right? If a kid's being physically restrained and secluded or subjected to that is traumatic, and getting help for trauma now really could do a lot to help you and your child down the road, right? By helping someone now with their trauma, as opposed to burying the trauma or saying, well, kids are resilient, they'll be fine. I don't buy that. I mean, saying kids are resilient is not a license to traumatize them. And then, of course, what can happen down the road? What happens with that trauma? Can lead to drugs and alcoholism and so many other at-risk behaviors. So acting sooner and acknowledging, I think, are so important. So this has been a fascinating conversation. Really want to thank you and thank the audience that joined us here today. Always encourage our audience, when you enjoy these and find them helpful, share them with others that you're connected to. And just want to, again, Sidney, thank you so much for your time and the work that you're doing. I know from our number of conversations that we've had that you are really dedicated to the work that you're doing and doing right by kids unapologetically. And, a group of people that I work with on quite a regular basis, they use the term unapologetic disruptor. And we need unapologetic disruptors. We need to disrupt and break some of the systems that are broken. And, this is not in an attempt to do harm, but rather to do good and make sure that we're raising human beings that are, that have the most potential that they can possibly have. So thank you so much for being here today. We're going to let our audience go. You can hang around for a second. We're getting a bunch of thank yous coming in now on the chat, and appreciate all those of you that have been on, or you maybe joined us halfway through. Go back and watch the rest. Thanks for being here, and we will see you again next time. Thanks.
Thanks, everyone.
Bye-bye.
Have a good day.